A very good morning. Thank you, Dr. Minal Joshi and Dr. Veenu, for inviting me. So we'll be talking about how to tackle the clinical exam. To understand what we do in the exam, we have to understand its purpose. We want you to be a consultant after this, a junior consultant, and you will not have other people, your faculty, to guide you at that time. It's possible that you may be working alone at that time. So you ought to learn those everything that you can do independently. So being independent after the exam is the most important aim of the exam. Of course, the exams differ from one place to another, from one university to the other, and the National Board of Examinations have their own rules. So go by your university rules. So everything doesn't apply to everybody. So what we will talk about is the strategies. Of course, to appear in the examinations, you have to study in depth and width both. And to understand how to examine patients and how to deliver your expertise to the patient, you have to develop a rational thinking. So these are the ways you have to learn to be able to do your exams well. Always remember, after the exams are finished, you will be afraid to ask questions. And you will say, where did you do your MD? Didn't you study in MD? And why didn't you learn all that stuff? So you have to be very comfortable to be independent in making a diagnosis and giving the treatment, not just one, but the options of treatment. So how do you have to have the studies? You start with how to examine, you understand, you learn from the methods of examination, and of course, take one book. I say that Bradham or DeLisa, from cover to cover, just like we do a complete part every day. So start from one end to the other, but in addition, study whatever patient that you have seen that day and whatever you discussed in the classes or the seminars that you had, and also the faculty asks you questions. So whatever questions are asked, they are very relevant for understanding as well as for the examinations. Don't be just stuck onto one or two books. You have to study additional books on the topics that are important from the point of view of seeing patients or having a thorough knowledge. So these are a few topics that you will have to have additional books. I tell you, during my DPMR examination, which happened to be only for 11 months, I had 32 books, which I read. So stages of preparation. Those PGs who start soon after they enroll are the best performers in their MD exam. Take, good part in attending classes, presentation of the cases, and also taking up seminars and the topics. We used to hold periodic examinations in our department. Almost every 3 months, a formal internal assessment examination, which gives you a good preparation for the finals. And it is very important when you see the patients in the OPD that you write a brief of whatever the patient's complaints were and whatever you examined, at least the positive findings. You will have a practice because the next time the patient comes, you will have a recollection of what you saw the last time. At the same time, that also gives you a food for thought for the remembering how to deal with a patient. Now coming to the practical examination per se. The day before, you have to revise your clinical methods because you may be asked, demonstrate this sign, demonstrate that sign, plus the discussions on that. And collect, not on the day of the examination, but day before, whatever you have to carry. An important thing is sleep well. On the day of the examination, get up in time, take a bath. Don't come with, shabby looks, shabby clothes that I couldn't sleep in the night and you are smelling bad. And do some light exercise that improves the functioning of the brain and gives you a good thought process. Always eat and be hydrated before the examination. And of course, this need not be said. It's very important that you have to carry all the documents. Many people forget even to carry their admit cards. We have seen in a number of places. The clipboard, you may get only a bed, where would you write on the sheet? Carry your own snacks and water. There have been times when during the examination I was not offered even a glass of water. Leave aside anything to eat. And of course you ought to have money in your wallet and a lot of confidence to go. These are just indicative things that you need to carry, but you may need to carry more than this. Just before the examination, to relieve the anxiety, it's always good to go to the loo. And just the way we say relaxation exercise, take deep breaths, 5 of them, that will reduce down your heart rate and the anxiety. And bring a smile to the face and say, yes, I can do it, no problem. And that makes a lot of difference at the time of examination. Of course, you are given 1 long case, 2 to 4 short cases, and in a few universities, 2 to 4 spot cases also. That depends on your local system that your faculty will tell you. Of course, when you deal with the patients, deal with them with a lot of respect and dignity. Don't treat them as subjects. Treat them as human beings. They're your clients that you are dealing with those. And this is being observed by the faculty, by the examiners. Look at the comfort of the patient. Some patients may be acutely ill or they may get damaged, like a spinal cord injury patient you see 3 weeks or 4 weeks after this, and you do the movements of the spine. That will become counterproductive. Respect the injury, respect the patient's condition, and do only those maneuvers which are permissible at that particular time. And I've seen the candidates touch the patient, and then the next time they do is this, and then they do this, and then they do this, and even turning the pages, they take they open their mouth and touch their fingers that. So that is taken as negative. You know the hygiene. You have to observe that. You don't have to keep doing this and that in the examination. And of course, when you talk about the patient, don't say anything which may be adversely taken by the patient or their attendants in front of the patient in case you are discussing with the examinations. When you are given a short case, people falter and they keep taking long history. We expect you to do a general physical examination and we allot you a place, like this is a region or this is a system or this is the part that you have to examine. You may ask just 2 or 3 questions. In case you ask many questions that start presenting the history, they will expect as if you are giving a long case. You are presenting a long case and you will, be in trouble yourself. But most important question is always ask what for the patient has come, so that you can tailor your treatment and the management accordingly. Usually, we say objectify the marking system. And this is the way we objectify asking questions and your preparation during the examination. And there have been instances when we have some very funny ways. I won't tell where, but the first question in the short case was, okay, what is your case? And they said, PPRP. Instead of giving the diagnosis in the beginning, start giving that this is name is so-and-so, and this is the age and the patient. I was asked to examine this, and I have found this, the general physical and the local examination. And the patient, the candidate kept on saying, PPRP, sir, PPRP. He wouldn't even say on this limb or that limb and whether this or that. And another example was there was an amputee, and when we said, what is your case, they gave a description of the stump, and they started giving the management. And the patient was blind. The candidate never ever saw the patient is blind. And how would you train such a patient? The whole management would change. So the importance of general physical examination is extremely important. Many a times you are asked to give just in case examiners are in a rush or you have had many, you are lamenting the history and other things, they will say, okay, just tell the positive findings in the general physical examination or the local examination that you do. So be ready with those positive findings. And many times when you have an amputee, which is more or less an order of the day in the examination, you would at least have 1 amputee as a short case, whether the stump is good or bad. What are the qualities of having a good stump? What are the qualities of a bad stump? So similarly, for different cases, you have to have the answers ready. In the long case,
National Board of Examinations as well as the MCI, the then MCI, asked for objective system of examination so that in case you just make a differential diagnosis wrong or a management wrong or just the diagnosis wrong, you are not punished that pass or fail based on that. So you have an objective system so that the candidates are given due importance to that, every aspect of examination. From Bradham, I have taken this. This is for the complete long case history. I'm not going to go into the details. You ought to know that there are so many factors, never leave anything. This is all written for you. So practice what is written, then you will not falter in your examination. So a couple of tips. When you are presenting a long case, start to speak and keep on speaking. Don't stop. After this, you wait for the examiner to ask you questions. In case you have stopped in between giving history, the examiner will fire a question, what else, you have forgotten this? Or in case you stop at one point, they will start asking you, going into the depth of whatever you have told, and they will not allow you to finish the history. So keep telling the history, general physical examination, as well as the diagnosis, then come to the problem listing and things like, so that you don't stop. That tells the examiner that you know what you are talking about. Most of the times, the people miss in their long cases is that in case the patient had an injury, patient had some intervention, patient was given some kind of a surgery, something was done. And with the passage of time, whether the patient improved, deteriorated, or whether there was any positive or negative thing after the intervention that was done during the treatment, people forget. So it is very important that you remember to include that in the history. Many a times, people also miss out on the past history, sexual history. Nowadays, I see there's a change in the trend, but previously, people used to be so scared of asking about their sexual habits and their problems. Hobbies and interests, because these can be helpful in the vocational rehabilitation at times. And when you're given a neurological case, people don't talk of the cranial nerves. When they're giving the systemic examination, they forget about that. And the last two things people often omit. What are the deformities, contractures, or local changes? Summaries, it is always best to give in 3 stages. After you finish history, give a reminder of 2 or 3 lines about the history, because examiners may be wondering about here, I got my TA or not, whether the cup of tea is here or not, and they're thinking of something else, so you give a reminder to them. After you finish with the general physical examination, give a brief of the positive findings so that the examiner also gets what is there. And he also knows that you know what is to look for, and you can present it finally. And after the systemic examination, again give the salient features. And it's extremely important to write a summary in 4 or 5 lines. People talk of half a page of summary. They start talking a history. Practice writing the summary for every case that you have in the long case whenever you discuss. For the sensory, you keep describing from here to here. It's not essential to describe. It is important to draw a diagram wherever you have a sensory deficit. And when you are asked to demonstrate a sign, because you have marks for that in the examination, don't keep telling, I will do this, I will do that. Explain it to the patient and start doing it, and tell the interpretation to the examiner that is what is needed. In the differential diagnosis, at least 2 or 3 similar things which mimic that kind of a diagnosis you must give. But at the same time, you also have to tell what are the distinguishing features in this patient, and this diagnosis doesn't fit well in that particular patient. And always say that I would like to do this investigation to find out whether it has this or that, and what is the positive finding in the patient. Should it be the positive finding in a particular case, or in that particular diagnosis that you are suggesting. So I would suggest that most of the people don't read the books on differential diagnosis. I used to read the French book of differential diagnosis. So usually I would utter only about 4 or 5 differential diagnosis. But after reading that book, I multiplied it by 5 or 6. Most of the times, differential diagnosis, you have these categories. that it is important, but for the particular patient, it may not be that very relevant based on the history and all. So I was yesterday looking at what are the examples of the differential diagnosis in a low backache. You see we have more than 100 causes of low backache. So what fits in? Even if you can 10 or 20% of these causes, examiners would be very happy. We don't expect you to tell us 132 causes which are given in the books, but you have to go from the skin to the bone marrow and from the head to the toe to think of what could be causing the problems at that particular place. When you talk about the diagnosis, you talk about the presumptive or the probable diagnosis. Don't say this is the diagnosis unless you are absolutely certain. And to confirm the diagnosis, you should say, I would like to do this investigation to confirm this is the diagnosis, and also to differentiate the differential diagnosis. Whenever you give some treatment, some medications, you are asked about what are the risks of those medications or what are the complications expected in the case. So how will I monitor the patient with the investigation? This is what is expected. So whenever you do a blood work or you write an X-ray, most of the times people say, I will do X-ray, MRI, ultrasonography, blood, urine, this, that examination. But what to see in that? Simply say, I will do this particular investigation, I expect the CRP to be high. I will do HLA-B27, it is likely to be high in a patient, it is likely to be positive in a patient with angst-pon. And give the positive thing that you're looking for in that particular investigation. That is what we look for. Any Tom, Dick, and Harry can get an MRI done without knowing what for he's getting it done. So you don't be a Tom, Dick, and Harry. Be a consultant. After you've given the presumptive diagnosis, write about the problem listing. Most of the times you ask the candidates about a long case given in spinal cord injury, they will say, the patient is not able to walk, this is the #1 priority list. Talk about all the factors. The patient has injury, whether that injury needs to be respected or you have to brace it or you have to operate it or things like that. What are the medical complications? You are a doctor first, so think of your domain first. And then look at what are the other domains of rehabilitation that you have to cover, and cover all those aspects. So if you have a list of this in your mind, think of all the subsections in your department, you will be able to do justice to the patient and to the case presentation. It's very important, we'll say what is the goal of the ultimate treatment. What is the expectation that you will offer to the patient at the end of rehabilitation. To reach that place, you have to have short-term goals and the long-term goals, and you will have to keep on modifying. So you have to think, what will I do immediately? And how will I reach the ultimate goal of, at the end of rehabilitation, where I will stop? But never ever start saying, this is a patient with spinal cord injury, and then what is given in the textbook on day 1 will do this, day 5 I'll do that. 1 month after I do that, 6 months after I do that, and these are the complications. See what is the problem with the patient and then start from there, rather than pick up from 0. When you are asked a question and you don't know, the best answer is, sorry sir, I don't remember, I haven't come across. Then the examiner would ask you, what will you do in case you get a case? The quick answer is, I will go and read, consult the books in the library and come back and see the patient again. So that is accepted. You're not supposed to know everything all the time. You ask me 100 questions, I may be able to answer only about 30 at the moment. Of course, Viva Voce has all these things. So remember that you understand. Unless you have the basic knowledge, you will not be able to talk about that. That is why I say read additional books and practice all those things before you actually come for the examination. Additionally, people also like to ask, because the examiners also check your theory papers that day or a day before, and in case you have made a mistake, they will ask you a question in case you have made a mistake, whether you have corrected yourself or that was a mistake. In case you made a mistake, you realize that in theory I made this mistake, you go and read and then have the correct answer. Similarly, thesis related. Some universities have also included thesis viva in the final examination now. In the examination, it is very natural that you have stress. What to do? You are shaking, you are not drinking, and then your legs are not holding you right, straight. And then we also tend to have those patients, I've seen it, a couple of candidates faint because they haven't hydrated themselves or eaten well. So always remember that you are seeing a patient in the OPD on the ward, and you are doing your job, and then if you have practiced with your faculty, then you won't have so much of a difficulty. And to practice, these are the common cases that you see on a daily basis. Practice 2 or 3 cases at least individually to the seniors in your department, and you will never ever fail in the examinations in case you have done at least 3 presentations yourself for these cases. And after the exam is over, recollect where you went wrong and read where you faltered, because you have to always keep on learning rest of your life. And never ever say that my exam is over, I need not study. Carry on studying, because exam is never the end of the story. It is just the beginning to make you a consultant, and you are a student always. Thank you very much.